All right, guys, this is your sexual health and sleep, which is chapters 33 and chapters 34. We'll start with chapters 33, which is going to be our sexual health, some key terms that are good for you to understand, some learning objectives that your book outlines. We're going to start with our reproductive anatomy of the female, the menstrual cycle, and the male reproductive organisms. So we know that the female has our ova. This is going to be our eggs that are produced in the ovaries, and they're going to travel through the fallopian tubes to the uterus. If fertilization occurs, the embryo will embed in the wall of the uterus for further development. Your vagina is the muscular tube that receives sperm during sexual intercourse and allows the exit of the menstrual flow if fertilization does not occur, and also serves as the birth canal at the end of pregnancy. We have all of the external genitalia, the vulva, the clitoris, the labia, both the majora and the minora. There's glands, there's the urinary meatus. Your clitoris contains your nerves, your blood vessels, and your erectile tissue. All of this area is very sensitive for sexual stimulation. And then we also have our breasts, which are the mammary glands enclosed within the breast and are also part of the reproductive system. And they function to produce milk to provide nourishment for our infants. When we talk about the menstrual cycle begins with puberty and involves hormonal changes that prepare the body for pregnancy. There's phases of the menstrual cycle that trigger hormonal changes. So the menstrual phase, menstruation usually lasts from 3 to 7 days, averaging about 5. During this period, the uterus sheds the endometrial lining and several ovarian follicles develop. The follicle stimulating hormone, which is your FSH, can be drawn as a blood panel. And this comes from your anterior pituitary gland to increase during this phase, leading to a rise of estrogen levels, which will lead you into your follicular phase. And the follicular phase begins the first day of the menstrual cycle and is associated with the growth of the ovarian follicles and regrowth of the endometrium of the uterus. This phase ends with ovulation, or the release of ovum from a mature follicle, so around 13 or 14 days of the menstrual cycle. Then we have our luteinizing hormone, which is an LH. Levels of the anterior pituitary gland rise, as does the estrogen level. And then we have our ovulatory phase. So this is when we're going to have a surge in LH and FSH that lasts about 16 to 36 hours. The follicle then ruptures, the egg is released for fertilization. Estrogen peaks and progesterone rises, which stimulates growth of the endometrium. In the luteal phase, if fertilization occurs, the endometrium thickens to support an embryo. The pregnancy hormone called chronic gonadotropin is produced. Pregnancy tests are based detecting the levels of this hormone. If fertilization does not occur, progesterone levels drops and menses begins. So now we can talk about our male reproductive tissues. So we have the sperm, and they're located in the testes, and they're transported through the epididymis into the ductus deferens, into the ejaculatory duct, and then through the urethra. Along the path of reproductive glands, which are your seminal vesicles, prostates, and other glands, add secretions that mix with the sperm to produce semen. The penis function is the urinary system to transport urine from the bladder to the outside of the body. It's also an important function of the reproductive system. And we know that ejaculation is the explosion of the sperm, is brought about by peristalsis of the reproductive ducts and contraction of the prostate. With each ejaculation, approximately 100 million sperm cells are expelled in about 2 to 4 cc's of semen. So concepts related to sexuality are gender, gender roles, gender identity, and sexual orientation. So when we talk about gender and gender roles, gender is biological sex, which is our male or female. And then we have our gender roles, which are your social norms for behavior. So your old stereotypes can come into here, where your gender role as a male is to be the breadwinner, and as the female is to be the home provider. Sexuality is an essential aspect of being human throughout life and encompasses sex, gender identities, and roles, sexual orientations, pleasures, intimacies, and reproduction. Your sexual identity is the person's perspective on their gender and their gender identity, gender role, and sexual orientation. All of these are also part of a person's overall self-concept. So when we start looking into gender identity, things have become increasingly complex. We can have non-binary or gender non-conforming. So in this, a person does not identify with any gender. Then we have transgender. So transgender is a broad term used to describe a person whose gender identity differs in some way from their naturally assigned biological gender. So if I'm naturally assigned biological as a female, but I identify as a male, I am then transgender. With transsexual, this is an older concept that refers to a traditionally referred individuals who permanently change or seek to change their birth sex. So this is going to be the female that dresses and wants to change to a male. Transition is the process of changing one's birth sex to another sex. It occurs over a period of time, and it encompasses numerous steps. We have gender reassignment surgery. So this is after extensive counseling and successful living in the opposite gender role for a period of time. Some individuals may decide to undergo surgical reconstruction to their external genitalia and remove their reproductive organs of the biological birth gender. Surgery is one process during this transition. Intersex are people that are born with ambiguous sexual organs. And then cross-dressers is a person who occasionally or frequently wears the clothing characteristics of the opposite sex, particularly undergarments, as a form of sexual expression. Often the person carries out this behavior in secret. Cross-dressers can be heterosexual, homosexual, or bisexual, which we're going to talk about those next. So when we talk about sexual orientation, based on the gender of the person who is sexually attracted to, hetero would be opposite sex, homo would be same sex, and bisexual would be both sexes. So if you're completing an admission assessment and the nurse learns that the female client has a female sexual partner, that would say that the patient, this data speaks to what? And it would be your patient's sexual orientation, right? So factors affecting sexuality. So we are sexual beings from birth to death. Expression of our sexuality evolves through our lifespan. And our culture can definitely influence our ideas about our gender role, about our gender identity, marriage, sexual expression, and social responsibility. However, it is not unusual for people to be ethnocentric, which we know is what we see as being us as normal, and we hold other people up to that. So if we do that, it can inhibit our practices, and it can make caring for people a little bit more difficult because we will not understand their sexual behaviors. So we shouldn't compare them to our own. Cultures in West and Central Africa actually accept polygamy, which is being married to more than one partner. We as RNs need to honor cultural practices unless they are harmful, illegal, or unethical, such as female genital mutilation. And we had just talked about how the female genitals can have some type of pleasurable sensation to them. And in some parts of the country, female genital mutilation happens for teenage women to prevent them from ever experiencing that. And between 97 and 2010, the World Health Organization has begun to abolish that practice. We have our religion. So we know that religious practices restrict premarital sex, birth control, homosexuality, abortion. And we just kind of went over a lot of that when we were talking about our cultural lecture. A lot of faiths do not believe in birth control. May believe that, you're not allowed to have abortions, no premarital sex, and all of that stuff. Our lifestyle, so family, social, economic status, employment factors, and interpersonal relationships shape our lifestyles, although they do not fully determine it. Our sexual knowledge. So community values play a large role in determining how sexuality is viewed and taught. Thus, even in a state of mandate sexual educations, a particular school may limit the discussion on reproduction of sexually transmitted disease, birth controls, intimacies, relationships, domestic abuse, rape, all of that, which can impact one's wellness. Health and illness, sexuality involves your body, your mind, and your spirit. So it's not surprising that health status can affect your sexuality. When we look at illness, heart disease and respiratory disease may cause people to need to restrict sexual activities because of fatigue, dyspnea, or fear of overstressing the heart. Diabetes may lead to neurological changes that may cause male erectile dysfunction. Women may experience vaginal dryness and loss of orgasmic ability. In addition, vaginal yeast infections are common with diabetes, causing itching and painful intercourse. Cancer may be accompanied by body image changes, fatigue, treatments that create nausea and fear of death, all of which can lead to feeling unattractive with a reduced desire for sexual activity. Spinal cord injuries may make it impossible for the person to feel physical stimulation. Depending on the level of their injury, the person may experience changes in physiogenic or reflectogenic genital arousal. Some men may achieve erection and ejaculation and are fertiles, and other will have no genital responses. And then we have surgeries. So when we think about different surgeries, if somebody undergoes a hysterectomy, which is the surgical removal of the uterus, this can enhance the sexual experience if it relieves pain and bleeding that were persistent beforehand. However, in contrast, if a woman reports becoming aroused or having less intense orgasms after a hysterectomy, this can then lead to problems of their sexuality. Same thing with mastectomies. If we remove a woman's breasts, they can lose their self-esteem. Prostatectomies remove the prostate gland. It's usually to treat prostate cancer, and it may be accompanied by erectile dysfunction and other sexual dysfunctions. You can have the removal of the testes, which usually is performed during testicular cancers. Males can experience infertility, which is associated with a loss of self-concept, reduced self-identity, and loss of intimacy. And then also colostomies, right? So we know that this is a surgical procedure that brings part of the colon to the abdomen, and a patient that wears the pouch has to express the feces through the pouch, and this can be very uncomfortable for them sexually after this occurs. They have body image difficulties. They may have fear about leakage, noise from flatulence, and pains, and also concerns about how their partner may react. So there's lots of factors that can affect somebody's sexuality. Then we have our sexual response cycle. So this is the sequence of psychological events that occurs when a person becomes sexually aroused. We have our desire, which this is a stage of varying length characterized by the interest in sexual intimacy. We have excitement. This is the next phase. This is the body's physical response to the desire. During excitement, we have bodily changes. So your heart rate, your blood pressure, your respiratory rate all increase. You might have muscle tenseness, and you have an increase in blood supply. Then we have our plateau, which is if the stimulation continues, you'll reach that plateau phase, which is also a continued increase in pulse, respiratory rate, blood pressure, muscle tension, and then orgasm can occur at the peak of the plateau phase. And then we have resolution, and this is when the body's going to relax and all of those increased heart rates, respirations, everything goes back to the pre-excitement phase. People all express their sexuality different, so we can have intimate relationships, and this is going to involve a willingness to take risks and trust others. We can have fantasies or erotic dreams, and these are going to be potentially increase your self-esteem and your sexual arousal and can serve as an outlet. We can have masturbation, which is several different techniques to it. It can be self-stimulation, or you can stimulate another person. That would be shared touching as well. We have intercourse, oral genital stimulation, anal stimulation, and then finally there's celibacy. And celibacy is the state in which an individual refrains from all sexual activity. So during a well check visit, a 14-year-old girl asks if it's okay to masturbate, which statement by the nurse demonstrates self-knowledge, and the answer would be D. This is the best answer, although the other ones could be potentially all right. The nurse has the responsibility to provide education to the patient and correctly answer her question. So when we talk about different sexual problems can be everything from sexually transmitted diseases to just a low sexual response cycle. And this is all stuff that patients could present to a nurse or a healthcare provider seeking help for. So sexually transmitted diseases are spread by direct contact with an open wound or with body fluids such as semen, vaginal secretions, or blood that contains pathogens. Your sexually transmitted diseases or infections can be caused by a bacteria, a virus, a fungi, or a parasite. Dysmenorrhea is going to be painful menstruation caused by strong uterine contractions that causes ischemia, loss of blood supply to the uterus, and most common among adolescents and women experiencing perimenopause. The patient may experience cramping, lower abdominal pain, back and upper thigh pain, headaches, vomiting, diarrhea. Treatment for this is typically bed rest, application of heat to the back and abdomen, analgesics such as non-steroidal anti-inflammatory drugs like an ibuprofen or an naproxen. We can have premenstrual syndrome, which is PMS. This is characterized by physical and emotional changes occurring 3 to 14 days before the onset of the menstrual period. Physical symptoms include headaches, constipation, breast tenderness, weight gain that's associated with bloating, abdominal swelling, swelling of the hands and feet. Some women feel though they are on an emotional roller coaster, they'll have periods of depression, anxiety, irritability, tension, and an overall inability to concentrate. We can have negative intimate relationships. So this is couples may be involved in a celibate or a loveless union for financial security, social status, for the sake of the children, or because of cultural or religious restrictions regarding divorce. The most negative relationships are those that involve domestic violence. They can also be called intimate partner violence, which may include physical and or emotional intimidation, assault, and rape. Sexual harassment occurs when a person in power makes unwanted sexual advances that expect or relate to the victim's employment, academic status, or success. Advances can take the form of sexual comments or behaviors, such as touching. Because the power imbalance, the victim may keep silent and suffer physically and psychologically. Sexual assault includes contact with or without penetration, touching sexual or intimate parts, and any unwanted sexual activity in situations of intoxication, coercion, or misconception. We go into rape. Rape is non-consensual vaginal, anal, or oral penetration. It occurs through force, by threats of bodily harm, or when the victim is incapacitated by giving, they're unable to give that consent. So like a date rape job. In states, laws consider rape within a marriage still a crime. And then we have our libido issues, so sexual response cycle disorders. So a low libido may affect both men and women. Factors contributing to hypoactive sexual desire include sexual trauma, a negative attitude towards sex, negative relationships, and biological factors, including hormone deficiencies, perimenopause, and a side effect of various medications. Low sexual desire in both men and women, in some cases, may respond positively to testosterone administration. We can have arousal disorders. In women, arousal disorders manifest as minimal or absent pelvic congestion and vaginal lubrication, even though desire may be present. Hormonal changes, the aging process, tampons and medications, including antihistamines, can cause this vaginal dryness. And it can also create painful intercourse, which further decreases the sexual desire. And then we can have orgasmic disorders, which is a delay in or an absence of orgasm after a normal sexual excitement phase. So obtaining our sexual history, right? We need to examine our own beliefs and values because we need to make sure that we convey a non-judgmental attitude and an unbiased approach. We need to be aware of our nonverbal communication. We want to be relaxed. We want to maintain eye contact, and we want to provide privacy. We need to watch for clues that the client's feeling uncomfortable or is concerned. And if we ourselves are uncomfortable with this, we need to kind of make it part of our regular practice. If we make it a routine assessment, then we'll become more comfortable to it. So if we have a 17-year-old client who comes into the clinic and states to the nurse, I think I have an infection in my vagina. After obtaining information on the signs and symptoms, what is the nurse's best response? Is it A, can you tell me what kind of infection you think you have? B, have you told your mother about your concerns? C, let's discuss your current sexual activity. Or D, do you know how you got this infection? And if you chose C, that is the correct answer, right? This one opens a dialogue about the person's sexual activity, which would be the potential cause for the infection. It's in a non-threatening and respectful manner. So if we're talking about the nursing process for our sexual health, we're going to start with our A of our ADPI, and that's going to be our assessment data. So what are we going to want to do, right? We need to think about things to ask. So pregnancy, infertility workups, requests for birth control, menstrual cycle irregularities or problems, annual health visits, or as part of a comprehensive physical examination, unusual discharge from or changes in their genital organs, urination problems, unknown sexual problems, illnesses, surgeries, medications, all things that could affect that sexual function. We're going to be either using the concept or diagnosis about an ineffective sexual pattern, or something to do with some type of sexual dysfunction. So common teachings that we need to look at. Teaching children about predators. This is one of those interesting things that for years we talked about stranger danger, and stranger danger kind of opened the doors to allowing predators like teachers and counselors to kind of creep in. So we need to teach our children about all types of predators, and we want to make sure that we set an open discussion for that. We also need to remember that parents need to be aware that children have normal exploratory periods of their age, and that at certain times it's completely normal that a child explores their own bodies. We have body function and reproduction that we can talk about. So with children, what questions do you have about sex? As part of your general discussion on sexuality and bodily function, we may wish to discuss common myths and misconceptions about sex. Douching, teach women that douching is unnecessary and it's associated with significant risk. It can wash out the lactobacilla that clean the vaginal area and protect it from infection. Women who douche are at increased risk for sexually transmitted infections and for pelvic inflammatory disease. Menstruation, it's a common misconception that women should not have sexual intercourse during menstruation. They actually are able to do so, and some actually find more pleasure in it. PMS, there's plenty of non-pharmacological treatments that we can do to help women who are experiencing this. Adequate sleep, small frequent meals, reducing sugar, caffeine, alcohol, salt intake, increasing vitamins and mineral supports can all be effective. If they need to go on pharmacological, sometimes we can use selective serotonin reuptake inhibiting drugs. So those are SSRIs, like Prozac, which is fluoxetine, or Zoloft. These are increasingly being used as frontline therapies for managing PMS. Menopause, we need to make sure that women who are experiencing menopause get to counsel, and they might need to go on hormone replacement therapy to help with symptom relief. Breast and testicular exams, we've already gone over those. We need to make sure that the patients are taught proper techniques because we do not want them to have false negatives. Preventing STDs, so we need to talk about proper use of condoms, encouragement of abstaining, use of contraceptives. Remember, if our patients are heterosexual or bisexual. We want to talk about how to prevent unwanted pregnancies. Counseling for sexual problems. We want to talk about permission. So you want to communicate an open, accepting attitude so that the patient feels free to ask open-ended questions. We want to give limited information. Supplying limited information may include teaching about normal sexual functions, expected changes in sexual functioning, medication side effects, and medical surgical impacts on sexuality. We want to be specific with our suggestions for self-care, and we want to be getting them therapy if they need it. We want to deal with inappropriate sexual behavior correctly. So as nurses, we are we're involved in intimate contact. We see people disrobe. We have to literally touch their bodies and discuss private topics. And in most cases, your patients are going to recognize that this is professional behavior associated with providing healthcare. But occasionally, we may have the response that's inappropriate. So if we believe that a patient is demonstrating inappropriate sexual behavior, we need to tell the patient that that behavior is inappropriate. We do not have to express anger, but we do have to use clear statements such as, you do not like their comment. They're inappropriate, they make me feel uncomfortable, please stop. We need to let the client know what behavior we expect, be direct with your comments. If the client's exposing themselves, let them know what you expect them to wear. I expect you to keep your pajama pants on. If the client is attempting to touch, we tell them, do not touch me. We need to refocus the client's intention to the care that we're delivering. You need to hold still while I take down your IV. If you're extremely uncomfortable or the patient persists to be making comments or actions, we can leave the room and report the incident to the faculty or to a nurse assigned to the client. However, if you're the nurse assigned to the patient, you may need to consider changing the assignment if it gets too bad. We do not want to ever make passive aggressive marks. We do not want to make a joke out of the situation. We do not want to be soft-spoken. We want to be very stern with our tone when we're making these comments of, do not touch me. And we never want to hit the patient, right? If the patient's grabbing at us, you're not going to want to swat them. You're not going to want to hit them. Just take their hand, move it away, and express, this is not appropriate. Stay still so that I can take your IV down. Okay. So next, we're going to move on to our sleep and rest. So these are the learning objectives for your sleep and rest. These are the key terms in sleep and rest. So what's the difference between sleep and between rest, right? The text has women resting and boys sleeping. What's the difference, right? When I took these pictures from your book, this woman is resting, this woman, and this boy is sleeping. So sleep is psychically occurring state, decreased motor activity and perception. Body function slow, the metabolism falls by 20 to 30%, so the body conserves energy. Sleep is characterized by an altered conscious. A person sleeping is unaware of the environment and responsive selectively to external stimuli. For an example, an alarm clock, bright light, or other meaningful stimuli usually awakens a sleeper, but everyday background noise and soft light does not. Rest without sleep is not adequate to sustain your life. At rest, the body is disturbed by all external stimuli, whereas sleep, it is screened from them by that altered consciousness. Thus, in sleep, the body restores itself, and during rest, we cannot restore ourselves. So what's the benefits of sleep? Sleep may improve your learning and your adaptation. It gives an individual a chance to mentally repeat and rehearse facts and situations before they are encountered in wakeful life. Some evidence suggests that sleep and dreaming may facilitate the storage of long-term memory, perhaps by assisting the brain in reorganizing and storing information. Older adults have an even greater need for sleep to protect against natural cognitive function decline that comes with aging. Sleep also appears to reduce stress and anxiety, improving our ability to cope and concentrate on activities of daily living. More sleep also reduces the body's sensitivity to pain. Sleep, rest, and illness are all interrelated. Illness and injury increase the need to sleep, and at the same time make it difficult to sleep. In turn, lack of sleep increases our susceptibility to illness by compromising the immune system. People who are ill or injured need more sleep than the usual to restore energy needed for tissue repair and healing. However, they often have a difficult time resting because of the pain and other illnesses. So your key terms to know here are your circadian rhythm, and this is a biorhythm based on day-night pattern in 24 hours. If you do shift work messes with one's natural circadian rhythm. Circadian rhythm affects our overall level of functioning. For example, most people have a higher level in the daytime and less energy at night. However, some people are more alert and active in the morning, and others function at a higher level in the afternoon or evening. If you can identify where your circadian rhythm gives you the most energy, it's actually your most optimal time to study and prepare for exams. The next one is our RAS. So the reticular and cortical neurons are called the reticulating activating system, which is the RAS. These are neurotransmitters associated with excitatory and inhibitory sleep mechanisms. They include your catecholamines, your acetylcholine, your serotonin, your histamine, and these things kind of promote feelings of sleepiness. Then we have our stages of sleep. So we have our non-REM sleep, which is your NREM, and that causes slow wave sleep because it's characterized by the presence of delta waves. If we were to do a sleeping EEG on a patient, your non-REM is divided into 4 stages. Each is deeper than the one preceding it. And then our REM is our rapid eye movement sleep, and it's essential for mental and emotional restoration. Loss of your REM sleep, your REM sleep, impairs memory and learning. All but your non-REM stage 1 are repeated 4 or more times a night. So this is the EEG that we just talked about in that last slide. The EEG is used to record the electrical activity of the neurons in the brain. We can do sleeping EEGs and we can do waking EEGs. EEGs are also used when we're talking about seizure activities, or if we're looking for brain activity to diagnose brain death in a patient. Some of the different waves, we have alpha waves, which occur during our drowsy stage. We have beta waves, which occur during periods of wakefulness. We have spindles, also known as K complexes. These are in the earlier phases of non-rapid eye movement sleep. We have theta waves, which are in deeper sleep stages. And then there's delta waves, which are common in our deep sleep. So if you ever looked at a patient's printout of these different waves, you would see how as we progress through our different stages of sleep, how we go through these different wave images. So factors that can affect our sleep, so many. So your book goes into great detail in how changes in our age can affect our sleep. And you can read over that. Other factors would be our sleep patterns. So newborns, young children experience prolonged REM sleep periods. Young adults spend about 25% of their sleep in REM sleep, and older adults typically enter REM sleep quicker and spend more time in this active phase of sleep. Your nicotine and caffeine affect your central nervous system. They're stimulants and they interfere with your sleep. Smokers tend to have more difficult time falling asleep and are more easily aroused than non-smokers. People who stop smoking often experience temporary sleep disturbances during their withdrawal period. Caffeine blocks adenosine and thereby inhibits sleep. However, individuals vary greatly in their sensitivity to caffeine. We have medications. Many medications people take can cause sleepiness or excessive grogginess and sedation. Medications to induce sleep are typically hypnotics, and they tend to increase the amount of sleep while decrease the quality of sleep. Ambien promotes a normal REM sleep and appears to influence sleep quite less than other hypnotics do. Also under medication, I want to just mention melatonin. So melatonin is actually a hormone that naturally causes sleep. However, it's now a supplement that you can get over the counter. A lot of patients swear by melatonin, but there's actual studies that say once our brain is saturated with melatonin, the receptors can no longer pick it up and it no longer works. So melatonin is one of those sleeping supplements that it'll work for like a few days and then they won't have the same response to it. And then after they go, several days without it, the receptors will lose the melatonin and then it'll be an effective sleeping aid again. And then illness. So again, we know that illness increases the need for us to sleep. And we need to make sure that we help promote sleep for our patients. Disease symptoms such as fever, pain, nausea, respiratory conditions can all interfere with sleep. And then I also have in here your environmental factors. So some people really need it to be either very cool to sleep, very warm to sleep. Some people need a low humidity and some people need a high humidity. A lot of times with little kids when they're sick, we'll tell parents to put a humidifier by their bedside because as they dry out, they'll wake up coughing and uncomfortable. Noises and light. Some people need a very dark, quiet environment. People that live in New York City, when they go on vacation to the country, sometimes have a very hard time adjusting to all the quiet because they're used to so much external noises. Noxious odors. I actually had a friend who had they lived in like an apartment complex. And they used to cook a lot of very fragrant foods, which would make it very difficult for us to get any rest because we always had those noxious odors coming through the vent. And then, of course, comfortable bedding, which, companies have made money off of for years. You want the softest, most comfortable mattress, the best pillows. We want a supportive pillow. We want something that accepts our side sleepers and stuff like that. So what are our common sleep disorders that we might come across? So we have two classes. This is one class. And this includes your insomnias, your circadian disorders, restless leg syndromes, hypersomnias. These sleep disorders are all characterized by insomnias or excessive sleeplessness. So when we talk about insomnia, insomnia is the inability to fall asleep, remain asleep, or go back to sleep. Insomnia can be transient, so short term, or it can be chronic, long term, more than a month. People with insomnia usually report an insufficient quantity or quality of sleep and awake without feeling refreshed, even though they often are observed to sleep more than they perceive that they do. If they have a circadian disorder, these abnormalities are in sleep-wake schedules may cause a rapid time zone change, so jet lag. Shift work can create circadian disorders or a change in total sleep from day to night. Symptoms include decreased vigilance, decreased ability to perform your psychomotor tasks, short sleep episodes, which are called micro sleeps, that the person's not aware of. People suffering from jet lag need several days to adjust their sleep-wake cycle. We have restless leg syndrome. So restless leg syndrome is the disorder of the central nervous system characterized by uncontrolled movement of the legs while sleeping or before sleep. It tends to run in families. It affects 5 to 15% of humans. Hypersomnia is people with excessive daytime sleepiness. So these are people that are going to nap or fall asleep at times when they should be awake. The sleep disorder that commonly causes hypersomnia is your obstructive sleep apnea or narcolepsy. Hypersomnia may be caused by disorders of the central nervous system, kidney or liver, or metabolic disorders as well. Sleep apnea is a periodic interruption in breathing during sleep. There's several different types of sleep apnea, but overall it's an absence of airflow. Typically, the soft tissue and the pharynx and soft plate collapse and obstruct the airway. Episodes may occur several or hundreds of times a night and may last for as long as a minute or even longer. During periods of apnea, the oxygen level in the blood drops and the carbon dioxide level rises. And this rise in carbon dioxide causes the patient to wake up. This may result in cardiac dysrhythmias and increase their patient's pulse and blood pressure. And then the finest one is narcolepsy. Narcolepsy is a chronic disorder caused by the brain's inability to regulate sleep-wake cycles normally. This distraction between being asleep and being awake is blurred at various times. So the person with narcolepsy experiences a sudden, uncontrollable urge to sleep lasting from seconds to minutes, even though the person's well rested at night. The person cannot avoid the sleep episodes, but awakens easily. Narcolepsy is characterized by sleeplessness, slurred speech, slackening of the facial muscles, a feeling of impending weakness of the knees, paralysis, and hallucinations. Performance is impaired during these micro sleep episodes. Sleep episodes can come on suddenly, and even when a person is having a conversation, they'll just fall asleep. So our common sleep disorders, these are your parasomnials. So these are going to be walking issues. So sleepwalking, which is where'd it go? I didn't see that. Okay. Sorry, guys. I had a little thing that I put in here, but I guess it didn't come on. So Sleepwalking is also known as somnambulation, and this occurs when the patient falls asleep and they'll get out of bed and walk. So this thing that we need to do when the patient is having those somnambulations is we need to make sure that we keep them safe. We're not supposed to wake the patient because it can actually cause them to have harm. We can have bruxism, and this is the grinding and clenching of teeth. It usually occurs during stage 2 of their non-REM sleep. It can eventually erode the teeth and the enamel and loosen teeth. The noise can also be very disturbing to the partner in the bed. Night terrors are sudden arousals in which the person, usually children, is very physically active. They're often hallucinating, and they express strong emotions such as terror. Children experiencing night terrors typically will cry and scream in fear. They'll thrash and resist all attempts by parents or other caregivers to hold or console. The child appears to be fully awake, but they're not. And then we talk about enuresis, right? And we know that that's a bed wetting. So we need to make sure that we're taking care of that. It can be incorrectly associated with dreaming. But, remember, we need to let parents know that it can happen and that it's completely normal. All right, so now our disorders that are provoked by sleep. So sometimes we can have this list of things and they get worse or they appear during our sleep. So coronary artery disease during REM sleep. Dreams may increase the heart rate, and this can provoke angina and EKG changes. People with asthma may experience bronchospasms during their REM sleep. In adults, asthma attacks frequently occur during the night as the esophageal sphincter relaxes and reflux starts. Chronic obstructive pulmonary disease, COPD. Persons with COPD experience lower oxygen and increased carbon dioxide levels due to the natural process of the disease. So during that REM sleep, when those neuromuscular control is depressed, this can result in pulmonary spasms, and they can have transient pulmonary hypertension. Diabetes, your blood glucose levels vary during your sleep. When diabetes is uncontrolled, it may profoundly affect the blood sugar level during sleep when the person is not alert enough to deal with it. Therefore, patients with uncontrolled diabetes may need to have blood glucose levels monitored during sleep. And we'll see this in the hospital that a provider will order blood sugars like every 4 hours, and they want them while their patients are sleeping. Our gastric and intestinal ulcers during our REM sleep, people with duodenal ulcers secrete up to 20 times more gastric acid than people that do not have these ulcers. Peptic ulcers also contribute to increased acid, often producing nocturnal epigastric pain and sleep loss. And then we have epilepsy. So these are seizures that are sensitive to our sleep patterns. Sleep deprivation can trigger seizures and increase their intensity or cause seizures to last longer. Some forms of epilepsy are especially reactive to sleep cycles and transition between sleep states. So the nurse is caring for a hospitalized patient who normally works the night shift at their job. The patient states, "I do not know what is wrong with me. I've been napping all day and I can't seem to think clearly. What's your best response?" And your best response is C. Didn't click. So data suggests that the patient is used to being awake at night and sleeping during the day. The hospital routine has disrupted their normal sleeping pattern. Um, we have, for which sleep disorder would the nurse most likely need to include safety measures in the client's plan of care? And the correct answer is C, narcolepsy. Narcolepsy can occur suddenly during daytime hours when a person is involved in any type of activity. This could put the patient at risk for harm depending on the activity that they were engaged. So when we talk about our nursing process for sleep, we're always going to start with our assessment. So things that we're going to assess, we're going to want to assess what's your usual sleeping habits, what's your normal sleeping environment, what's your bedtime routines and rituals. Do you use sleep aids? Have you experienced any sleep changes or problems? These are all good things that we would want to find out. Then we talk about our nursing diagnoses or our nursing concepts. We can be looking at things like, are we having sleep as a problem? Is it impaired? Or are we at risk for an injury? Are we at risk for fatigue? Are we having ineffective coping? Are we having some thought process or some anxiety? So then after we decide what we want, now we're going to want to do our interventions, right? And our interventions, one big thing that we can do is we can cluster care to avoid any unnecessary interruptions in their sleep and rest, right? Unless the patient's critically ill, we do not want to wake them up, even for those motoring vital signs if they're sleeping. And I know that that's not common practice, but you want to let our patients sleep as much as possible. And we want to create that restful environment. Many people find it very difficult to sleep in an unfamiliar bed, even if it's a comfortable one. Hospital beds are not noted for luxury, but we can help make them more comfortable. We can be sure that bed linens are tight on the bottom and loose on the top to allow for movement. We can make sure that the linens are clean, dry, and free of irritants. Perspiration on hospital gowns or linens can give a chill to our patients. We want to have good body alignment. We want to give them extra pillows. A blanket from home is always a great suggestion. We want to make sure that we can keep the room dark and quiet unless the patient prefers light. As much as possible, we want to be able to give them the temperature control that they want. So we need to make sure that we ask the patient what temperature they like to sleep at. We want to promote comfort. So if they're having pain, itching, and nausea, these can all be deterrents to sleep and to rest. So we want to make sure that we can address those as possible by offering medications. And we also want to use things like fluids, cool cloths, even a back rubber back massage can be helpful. And we want to support their bedtime rituals and routines. So most people have some kind of routine before going to bed, be it reading, watching TV, drinking warm milk, praying, meditating, whatever it is. We want to make sure that we include any routines or rituals in the nursing care plan to ensure continuity and obviously give smoking education to people that smoke not to. Again, we want to make sure that we give them the appropriate temperature they like to sleep at. And if they're still having issues, we can have them keep a sleep diary. Typically, a sleep diary will help them analyze times of difficult sleeping or feelings of unrestfulness during the day. And then when they look back at their diary, they might be able to pair it together with certain foods or things like that that can highlight different alteration changes in their daily living. So as a nurse, your sleep is extremely important, right? They say that if we're fatigued, it can impair our judgment and our decision making. So you need to make sure that you're well rested before your shift. If you're doing shift works, you need to make sure that you take breaks. If you're doing consecutive days of shift work, rest during those time periods. I don't know how many nurses I've worked with night shifts over the years that have decided that even though it's only a 12-hour night shift, they're going to use the other, 6 hours a daytime to accomplish like all these mega chores and then they come back the following night and they're exhausted. We want to make sure that we're smart about caffeine use. And we want to avoid going to bed frustrated. We go to bed frustrated, we're going to ruminate over it, and we're not going to be able to get adequate sleep. And we want to make sure that we get adequate sleep. And that is the end of this lecture.